I'm Chris DeBoe with the Canadian Arthritis Patient Alliance here at the CRA 2014 Annual Scientific Meeting. And I'm sitting with Angelo Papachristos from St. Michael's Hospital in Ontario.
In Toronto,
who is the
advanced practice physiotherapist.
advanced practice physiotherapist.
That's right.
Just a few questions. I just attended your workshop on physiotherapy and back pain, knee pain, and shoulder pain. That's right. Yeah. If you could, and I know it was sort of focused on mechanical pain. The other side of it is inflammatory pain and arthritis, which is sort of a subject that's close to all of our hearts. If you could tell me a little bit about the difference in treating those two. I know that there's lots of sub categories of arthritis. What's the difference, the main difference between treating mechanical and inflammatory pain?
Well, I think, Chris, the focus of the lecture this morning was what kind of tools, what kind of entry-level exercise or advice can a rheumatologist or a nurse practitioner or someone else in the community who's not obviously trained in providing focused exercise prescriptions such as a physiotherapist, which is what we do. So the talk of this morning was 90% of the patients that come through will end up with some sort of mechanical type symptoms, back pain, which is a very common condition. Like I said, probably 100% of the patients, people that attended that lecture this morning will end up with some form of low back pain or knee pain in their life.
Mm-hmm. It's called life.
It's called life. And the message there was to address what kind of things that you can do just to get started before you see that professional who's trained in sort of fine-tuning your therapy program. And the number one message was education on back pain. And the number one thing is to make sure that when you leave your office from your family practitioner or your rheumatologist or your nurse practitioner, message number one is bed rest is bad. Okay, any type of movement is a good thing. So initiating that from day one, the fact that this is a condition that needs to be managed over time, that the strategy is that there's tools that you need to implement which are muscle and fitness related. They should be adopted right away to get out there and focus on lifestyle management issues such as weight reduction strategies, overall fitness and conditioning, strengthening your muscles. For specific, we'll talk a little bit about the low back pain, and a lot of that is core stabilization type exercises, focusing on lifestyle changes, work-related modifications, maybe doing Pilates classes, things to get you on the road to sort of long-term change, so that you can manage recurrent symptoms. When we're dealing with inflammatory type low back pain, such as in ankylosing spondylitis, we take a little bit of a different approach. Some of those strategies are the same, but a lot more focus is placed on range of motion and postural retraining. For example, maintaining the mobility of the spine, focusing on stretching out your iliopsoas muscles, your hamstrings, working on the core, but focusing on sort of more posture retraining exercise and fitness, because it's a lifelong disease management. And there's excellent medication, as you see at the conference today. A lot of the biological medications are mainstream therapy for patients with ankylosing spondylitis. However, they deal with sort of the symptoms and the underlying process, but that in the long run, a patient or a person living with this, even if they're on some of these medications, have to focus on the second part of it. Right? So medical management is the one focus, but looking at physical function, getting into a good long-term strengthening program and conditioning, range of motion, posture exercises, and sort of hobbies or recreational activities that they feel they can maintain over the long run is the way. So you got to work on the conservative management that complements the medical management that you see the rheumatologist perform here. So the two have to be done together to maintain good benefit.
If somebody comes into your clinic and they've been diagnosed with arthritis of any kind, are there some really basic things that right away you tell them to do before they get a specialized program?
Just like we discussed, number one, a lot of the questions were surrounding knee arthritis. So a lot of it is osteoarthritis or degenerative type of arthritis.
Yep.
A single thing that we find, at least in our clinic, because a lot of the patients are surgical patients waiting to undergo joint replacements, or they've been referred for pain-free replacement. Number one thing is weight reduction. Okay, weight management, and
what impact does weight have on joints?
well, it's a strictly mechanical and loading phenomenon. Right? So the more you're carrying up on top here, all the force distribution goes to the joints. Also, if you're a little bit on the heavier side, of your BMI is heavier, it's a lot more effort, expenditure-wise, that you're trying to conduct through these physical activities. It might be harder for you to comply with some of these activities. They've also done studies that it's just not a loading phenomenon, that the fact that obesity actually releases mediators that are inflammatory. Okay. So we no longer think of it sort of as a degenerative disease, but there is an inflammatory component and a systemic component to being overweight and having obesity or fat tissue. So the fat actually releases these cytokines and these mediators.
Yeah.
So we sort of switched the paradigm to thinking that obesity is just sort of weight loading phenomena. You know, it is an entity in itself.
That's interesting. What are some of the things that from a physiotherapy point of view, people with arthritis need to be careful of, or need to consider, or maybe even avoid?
So we had this conversation in the lecture. For example, a lot of the arthritic conditions that you would see here at this rheumatology conference, spondylitis, rheumatoid arthritis, etc., are considered arthritis of some type. And you need to sort of make sure that when you're going to a therapist in the community, that they have some understanding or conceptual idea of how to treat these conditions. It's mainstream now in rehabilitation to be getting adjustments or manipulations. So if you're having ankylosing spondylitis, there's something that you need to make sure that you're going to someone who understands some of the contraindications to manipulation in someone with spondylitis. Rheumatoid arthritis, same thing. Other things that are mainstream now, maybe in Toronto, but I'm sure in Vancouver here and BC as well, is things such as alternative and complementary therapies, such as acupuncture. Yes. And we use it a lot for symptomatic relief of joint and muscle disorders. You just have to make sure that the clinician is well versed in sort of these specialized arthritis conditions, because the biologic medication and disease modifiers have implications from an immunosuppressive condition, and the risk there is, of infection and other complications. So my advice is, working on the fitness aspect is great, but after a few months, you should always make sure your rheumatologist or your family practitioner will gear you towards someone who has some training in the area that you're looking for, just to make sure that you're maximizing your function and minimizing your risk.
Right on. I've had arthritis since I was 13, so I'm a huge consumer of physiotherapy services. Have always been, and I've seen changes over the course of my life in the last 30 years. What would you say are some of the major shifts in kind of the way physiotherapists are treating people or thinking about these things in the last 5 or 10 years? Are you seeing anything?
I think there's a closer link with the rheumatology community, whereas in the past there wasn't. At least unless you were in the rheumatic disease unit. I think there's a better understanding in the community with physiotherapists. For example, we have the ACPAC trained therapists in the Ontario with some exclusion. That's advanced clinician practitioners specializing in arthritis care. So this is sort of an area that was identified, that you have your basic knowledge in treating physical disorders and but there's that extra little bit of training that you're required to be able to assist and complement what the rheumatologist is able to do and assist patients. So there's that role. The more you understand the conditions, we're able to fine tune the treatments that we have to better help you. But in the long run, walking, aqua fitness, weight loss, lifestyle management issues, assisting patients function in their home life with assistive devices, helping patients modify their work environment to be able to go back to work. A lot of that hasn't changed. A lot of it's basic, but requires a lot of education and patience, and having the patients understand where to go, where to get the service. Technology's changed in social media and using, for example, pedometers, monitoring your exercise abilities using online programs. So there's a lot of that technology aspect that has been implemented in rehabilitation, but a lot of the basic early on stages has not really changed a whole lot.
Right.
Manipulation for low back pain, still manipulation for low back pain, strengthening. I think is pretty much the same. It's understanding how we can fine tune and complement it.
Great. For people who may not have a physiotherapist engaged currently, is there a way for arthritis patients to find out what physiotherapists in their area may know more about, say, some of the arthritis conditions than others?
I think first thing is to make sure you talk to your family practitioner, because geographically there's a lot of variance, so your rheumatologist will be able to treat you. They'll be able to guide you to where the appropriate resources are. The Arthritis Society, for example, has information on their website that will be able to gear you to take that first step, to be able to ask the right questions when you go back to your rheumatologist or your family practitioner, and to ask your therapist when you go in. If you're asking basic questions on the condition and conceptually they don't really understand what's going on, it's maybe not a good idea that you continue to see them. But the local organizations, for example, the Canadian Physiotherapy Association, they have a website to be able to connect with physiotherapists in your area. And again, provincial bodies that have lists of therapists where you can find someone that's specially trained in treating these conditions. In Ontario, we have the APAC therapists, so the advanced clinicians, practitioners in arthritis care, which are composed of specially trained physiotherapists, occupational therapists, and now we have nurses that are also enrolled in the course that are sort of trained to a little higher level in these conditions. So if you live in sort of those areas, you can track one of us down. There's about 47 of us.
Yeah.
We'll be able to take you to the right area.
That's great. One last question. Besides the possibility of going skiing, what do you think is the most exciting and important thing that you feel is coming out of this scientific meeting this year?
From an allied health professional standpoint, I think the interaction with rheumatologists and the growing understanding that treating patients with arthritis requires a more comprehensive approach. We're very pleased to be part of this meeting. We have the Allied Health Professional Association here. It has been integrated fairly well into the agenda here. We're having posters and sessions that are separate from the CRA. But the interactions and the understanding that you will require your pharmacist, you will require Arthritis Society, your therapist, your nurse, to be able to fully maximize and assist the patient with their needs is what's exciting from my perspective. From the scientific perspective here, what I find is fascinating is the whole entry biologic discussion, and I think there's some sessions here that the Arthritis Consumer Group brought up yesterday about being a voice from a patient advocate standpoint. I think there's a lot of areas that need to be addressed with this. I think patient groups are really fired up to see how they're going to be managing this.
Yeah.
So I think some of these new medications that are coming up that are not generics, coming off as biologics for some of your patients that might be on this. This is sort of the area I think in the next 6 to 12 months that I think your approval will be looking into a little bit more closely, and how that's going to impact those patients.
Yeah. Well, thank you very much. Appreciate your time.
My pleasure.
All right.
Take care.